A very good morning to all. I am Dr. Sachin Goyal, and the topic of my today's seminar is Principles of Swallowing Therapy. We would be covering the following topics: the goals of swallowing therapy, various indications, the different management strategies like dietary modifications, compensatory and rehabilitative techniques, a few cases, and the recent advances. Swallowing therapy has the following goals. The most essential goal being to maintain a safe swallow, that is, to reduce the risk of aspiration or penetration. We want to improve the ability to eat and swallow, hence enhance oral feeding, and to optimize the nutritional status of the patient. The various indications can be stroke, dementia, various head and neck cancers, preoperatively and postoperatively, head injury cases, conditions with reduced saliva like Sjogren syndrome, muscular dystrophies, neurological diseases like Parkinson's, and post-radiation patients. Now, when a patient is referred in the outpatient or inpatient department, a bedside exam with swallowing screening and clinical history needs to be done. If the patient passes that sufficiently, then a trial of oral feeding is given and the patient is referred back to the physician. However, if the patient fails the screening tests or gives a history which is significant of a swallowing problem, then we do a clinical swallowing evaluation. That is, we obtain a fiber optic evaluation of swallowing, and then treatment is recommended accordingly. The various management strategies are dietary modifications, compensatory techniques, and various exercises to rehabilitate the patient for swallowing and non-swallowing exercises. The dietary modifications are used if one aspirates only on certain substances. Various adjustments in the bolus volume, speed, and the mode of the delivery can be done to rehabilitate the patient. It is based on trial feed outcome, that is, trial is given during the scopy examination and the outcomes are assessed. The International Dysphagia Diet Standardization Initiative has given various scales for the thickness of liquids and foods. For example, liquids are graded from 0 to 4, from thin to extremely thick, and foods are graded from 3 to 7, that is liquidized food to a regular consistency of food, and these can be varied according to the patient's requirements. Now, this is the summary. If the pharyngeal squeeze of the patient is weak, but there is adequate laryngeal adduction, then patient aspirates semi-solids due to residues. Hence, the preferred consistency is watery. Whereas, if the squeeze is strong and laryngeal adduction is weak with a phonatory gap, then patient tends to aspirate thin liquids, and the preferred consistency should be semi-solids or thickened fluids. Whereas if both are weak, then the patient can aspirate both liquids and semi-solids. Hence, oral feeding is not recommended and only ice chips are given to make the oral cavity moist. The various dietary modifications can be: when thin liquids are given, reduced tongue-based contraction and reduced pharyngeal contraction is assisted due to gravity, and patient is able to take these feeds. However, thickened and pureed feed should be given in cases where there is poor tongue control or reduced airway closure, so there is decreased aspiration to liquids. And slowly these consistencies are modified and we progress to a general regular diet. There are certain thickeners which are commercially available in the market, like this Thickenup from Nestle. The thickness or the consistency of the feed can be modified by the number of scoops that we add into the feed. Various home remedies like maida, corn flour, or atta can also be used instead of these commercial preparations. Now coming to compensatory techniques. These are basically short-term adjustments which control the transport of bolus and prevent aspirations. The aim is to teach patient these postural maneuvers to compensate for the swallowing difficulty. These are the various compensatory techniques which we'll just see in detail. The first one being a chin tuck maneuver. Chin tuck. The chin is touched to the chest while swallowing, and what it does is
don't swallow.
we can see that it opens up the valvula and helps in better oral containment, hence preventing spillage. The tongue base and epiglottis are approximated to the posterior pharyngeal wall and the airway is narrowed, decreasing the risk of penetration and aspiration. Next is head turn.
Head to the left.
We can see how it is being performed.
Head to the left.
And now what it does is,
hold it.
in the above video, we can see the head is being turned to the left. This leads to the opening up of the right piriform sinus. Whereas in the video below, the head is being turned to the right, which leads to the opening of the left piriform sinus. The idea is to turn the head to the side of the vocal cord weakness so that that particular piriform sinus closes and most of the feed is directed towards the strong side. This prevents aspiration in the patient. The next maneuver being head turn and neck bend. Here we can see that the head is turned and bent. Now what it does is,
Bend to any one side. Just little bit bend.
as we can see, the head is being bent to the right side, leading to the complete opening up of the left piriform sinus. Now, this maneuver is performed by turning the head and bending it towards the strong side. This is to assist the gravity in the movement and the propulsion of the bolus from the strong side, avoiding the weak side. Now, what is the difference between compensation and rehabilitation? The compensatory maneuvers are usually attempted during the instrumental exam. They are primarily manipulated by the clinician and they require limited cognition. They can be assisted. The benefits are immediate, but they are never permanent. They are aimed to secure safe and adequate oral intake for the short term or while the maneuvers are being performed. Whereas rehabilitative strategies, they alter the swallowing physiology. They require a good cognition on the part of the patient, but the most important benefit is that the changes in the physiology lead to permanent benefits to the patient. Coming to non-swallowing exercises, which are also called indirect therapy. These are various oromotor exercises, that is, rounding or spreading of the lips, achieving an adequate lip seal, movements of the tongue, elevation, lateralization, protrusion, exercises of jaw, resistance exercises, or various desensitization techniques like stroking, brushing, or applying pressure. These are the examples of various oromotor exercises. The first one we can see it's a tongue glide. The second one is the lateral mandibular exercise with a lingual glide happening at the same time. Then we have various exercises where we give pressure to the jaw and the patient is made to open the jaw or close the jaw against resistance, leading to physiotherapy of the jaw. Then there are various exercises of the tongue where a spatula can be used to provide resistance and various forward, lateral or tongue protrusion exercises can be done. Coming to direct swallow therapy, these are the basic rehabilitative exercises. The first one being effortful swallow. This is how it's done. The patient clenches both the hands in the midline and tries to produce pressure against them. What happens we can see. Because of the pressure that the patient is exerting,
Yes.
you can see that there is complete closure of the endolarynx, bringing both the vocal cords in the midline. This not only increases the lingual force on the bolus, it also maximizes the posterior base of tongue movements, increasing pharyngeal pressure, and there is improved clearance of the bolus from the pharynx. Now coming to supraglottic swallow, this is how it is performed.
Deep breath. Hold.
Patient is told to take a deep breath, then swallow, and then immediately cough after the swallowing is done. We can see what it is,
Inhale.
what happens endoscopically.
Hold. Swallow. Once more. Supraglottic.
See again,
Inhale.
holding the breath closes the endolarynx, then the swallow is performed, and we immediately cough to extrude any bolus which is penetrated or aspirated into the endolarynx. Hence, it is recommended for a reduced airway closure, closes vocal folds before and during the swallow to prevent food entry into the airway, and it changes the timing of the upper esophageal sphincter opening, changing the timing of the hyoid excursion and improving laryngeal closure. Supraglottic swallow is another modification of the same procedure
Inhale.
where
Hold. Swallow. Cough out.
in addition to the above maneuver, patient is putting pressure on the arms of the chair.
Okay.
Now, what extra do we achieve by this?
Inhale.
You can see
Hold
by
tight,
exerting
please,
pressure,
right now.
the endolarynx is completely concentrically closed.
Once more. Inhale.
This complete closure of the endolarynx
Hold. Bend down.
will protect the airway against any aspiration. Effortful breath holding causes the arytenoids to tilt forward, leading to an anterior posterior contraction, thereby closing the laryngeal vestibule. Now coming to another important maneuver, which is Mendelssohn's maneuver.
Swallow. Can you feel the elevation? Okay. Now what you have to do is swallow, and when you start feeling the elevation, hold it there.
Okay.
Hold it. You hold it for few seconds, and then you swallow. When I tell you.
See, patient has to hold the swallow.
Hold.
After the hyoid rises up, you can see endoscopically that by holding the swallow, it gives more time for the cricopharyngeal sphincter to open. This is both a compensatory and a rehabilitative strategy, provides an immediate effect by opening the cricopharyngeal sphincter, but also improves our pharyngeal contractions, helping the clearance from piriform sinus. Now, Masako maneuver. The tongue is held between the teeth and then the swallowing is performed. It's a non-invasive exercise which attempts to target and recruit the muscles for pharyngeal contractions, brings pharyngeal constrictors closer to the tongue base, and hence positive results can be expected in cases with decreased tongue base retractions and weak pharyngeal contractions. Now, the Shakir's exercise. By keeping our shoulders touching to the ground in supine position, the neck is lifted and we try to view our feet. It's a non-invasive exercise again to strengthen suprahyoid muscles, provides an alternative to the cricopharyngeal myotomy or Botox injections, and positive results are seen on reducing post-swallow residues and enabling the tube-fed patients to return to normalcy sooner. This is a similar exercise, chin tuck against resistance, as Shakir's achieves the similar benefits, where the participant is seated and tucks an inflatable rubber ball between the chin and the chest. It is less strenuous than Shakir's exercise, and hence allows better compliance for the patients to perform. Now, how a swallowing therapy should be planned. Adequate understanding and assessment of the FEAST exam is critical for planning a swallowing therapy. The diagnostic markers being cough reflex and sensations, which have to be checked. Any pooling of secretions, residues, spillage, any mismatch between the swallow initiation and aspiration penetration have to be assessed, and then the therapy has to be given accordingly. Now, what are the various spillage patterns? Now, what is spillage? Here you can see the liquid entering the pharynx much before the swallow was initiated. So spillage, if it occurs during the oral preparatory phase, it is basically due to a poor oral containment, and oromotor exercises and chin tuck can be done to rehabilitate the same. However, if it occurs during initiation, then a delayed or a mismind swallow is the main cause, and then swallowing therapy has to be initiated for the patient. Again, coming to management, various oral range of motor exercises, sensory stimulation, supraglottic swallow, and Mendelssohn's maneuvers for the swallowing therapy can be taught to the patient to improve spillage. Coming to aspiration or penetration, if the aspiration or penetration occurs before the swallow, it is due to a delayed initiation of swallow. During the swallow, due to incomplete laryngeal valving, that is, there is incomplete closure of the endolarynx. And after swallow, it occurs due to an incomplete bolus clearance, leading to residues in the valvula or in the piriform sinuses, which tend to get aspirated or penetrated with each breath. Now, residues are a sign of ineffective swallow, which is mainly due to reduced or problematic tongue propulsion, reduced epiglottic retroflexion, decreased hyolaryngeal elevation, which leads to decrease in the opening of the upper esophageal sphincter. Residues can be cleared by altering the food and liquid boluses. Compensation can be given using head turn or chin tuck maneuvers, whereas rehabilitation can be provided by effortful multiple swallows, Mendelssohn maneuvers, or Shakey's exercising, depending where the problem lies. To summarize swallowing therapy, a patient having a good sensory or a good motor control is ideal for direct therapy and rehabilitation. Whereas a patient with a poor sensory and a good motor control, they are the ones which tend to aspirate. They are called silent aspirators because the poor sensation leads to a poor cough reflex, but they can be considered for intervention, but cautiously. Whereas patients with a good sensory and a poor motor control, they tend to have weak swallowing movements but a good cough reflex. We have to be cautious while intervening because they'll be having a lot of residues and they have to be managed accordingly. But a patient with a poor sensory and a poor motor control is a poor candidate for swallowing therapy, and enteral feeding should be continued in such scenarios. Now, this is one example of a FEAST examination, how we detect the problems and we manage. Please observe that the bilateral vocal cords are mobile. On taking liquids, we can see good clearance to liquids with no penetration or aspiration happening. However, when the patient starts taking semi-solids, he is not able to swallow them due to a poor pharyngeal squeeze, leading to multiple residues in the valvula and the piriform sinuses. So, the dietary modification can be that liquids can be adequately given since the patient had a very good clearance of liquids. We reduce the semi-solid boluses and water can be given to clear the residues after every semi-solid bolus. Compensatory maneuvers can be an effortful swallow or repeated multiple swallows, which will help him clear these residues. And rehabilitation has to be performed to strengthen the pharyngeal squeeze, and this can be achieved by giving multiple rounds of Shakir's or CTAR exercise. Now coming to recent advances, the one of them being Vital Stim. It is based on the principle of neuromuscular electrical stimulation. Surface electrodes are placed over the skin, over the neck, over the suprahyoid muscles, and small electric currents are carefully calibrated and administered. The current stimulates the motor nerves and in turn causes contraction of the muscles involved in swallowing. The sessions can vary from 30 minutes to 1 hour, and these in turn also help in strengthening our swallowing muscles and rehabilitating the patient so that good oral feeds can be started sooner. EMST, which is expiratory muscle strength training, is a device that helps in strengthening the breathing exercise and the expiratory flow. The various degrees of resistance can be provided against expiration, and it has been observed that it also helps in strengthening the suprahyoid muscles, which in turn will improve the swallowing outcomes for our patients. Last but not the least, oral hygiene is very vital to our plan. We should add a comprehensive oral hygiene program for our therapy routine because preventive effect of oral hygiene on pneumonia and other respiratory infections is very vital for our patient rehabilitation. To conclude, swallowing is a multidisciplinary management. Early screening should be done. Prompt referral and instrumental assessment should be performed to assess the deficit that the patient may be suffering from. Individualized management plans have to be created for every patient because there is no standardization, and individual fees findings will only help us treat the patient. Restorative swallow therapy to optimize the nutrition, hydration, and we should also ensure airway safety because recurrent aspiration pneumonias can be very detrimental to our patients' well-being. Caregivers have to be educated adequately for proper treatment of the patient, along with the meticulous oral care and hygiene. That would be all for today. Thank you.